All right, welcome back. And believe it or not, the sixth annual Global Neuroscience Institute Neuroscience Conference is over. So I just want to thank everybody for the last 3 days. We had an absolutely incredible turnout. I don't think anybody was expecting this degree of success. We decided early we wanted to do something different. We wanted to try a different format. A different type of technology, and thanks to everybody out there. It went, and everybody boots on the ground here went incredibly well. Thank you for your surveys, the evaluations. They've really been all really positive and helpful. Thank you to our industry sponsors. We're going to scroll, so please look. You'll see all of our sponsors, from our gold sponsors on down, all the people that help make this possible. I really want to thank all of the speakers and all of the participants as well. We've had, again, well over 300 participants, multiple contacts, collaborations amongst all of you, which is, for me, the most exciting thing, that we're kind of getting this community and ecosystem together. So what we'd like to do towards the end, in the last final half an hour here, is I'm joined by some of the colleagues here from the panel, Dr. Sarkar, Dr. Lovin, and Dr. Binning. And we really want to answer any questions from really the last 3 days. There can be any questions whatsoever. We have a couple that we're going to go over that have already been sent in, but while we're doing this, please continue to ask questions. Anything out there, there's no dumb question, which actually isn't really true. There are dumb questions. People say it all the time. But for the purposes of this type of conference, there really are no dumb questions. So why don't we start with some of them to get the ball rolling? I think, Tom, you have some.
Sure. So for Dr. Sarkar, DBS, the question was, has the technology changed enough to decrease limits on MRI tests?
So that's perfect, because people who have DBS have other problems that are going to come up where they'll need an MRI of their brain again or of their spine, and indeed that's what the manufacturers are all gearing up to. Just because the technology is better, though, doesn't mean that your individual radiology imaging center is going to believe those parameters. So we would say, come to a center that's used to doing DBS, and then we can convince the radiologists that they can get those scans.
Next question was related to memory loss. Since there is no treatment for vascular dementia, are there any studies on upcoming medications to treat this type of dementia, clinical trials, etc.?
Well, first of all, I'll open this up to all of the panelists here, but as you've heard over and over again, and I think one of the things that we like to point out is, instead of sitting on our laurels and pretending that we know answers to everything, or continuing to look at data and trials and medications that we know don't work, the problem is the dementias, particularly Alzheimer's disease, we don't really have a good understanding of what the cause even is, and that's why we've chased plaques and tangles. We've chased all these types of etiologies, but we've come up dry with treatment. So for vascular dementia, that's a very different, I think there is a better understanding of that, of small vessel disease, and it's a bunch of mini strokes that become cumulative to the point of causing cognitive deficits. The old terminology was Binswanger's disease, which, us older folks remember that. That was the working diagnosis. So as far as medications, there really is no specific medication. It's really prevention, and once the correct diagnosis is made, being able to help prevent continued small vessel disease, antiplatelets, and statins, things like that. I don't know, Mandy, as a vascular, if you have any.
I agree. It's really all about prevention. 80% of strokes can be prevented if you treat your risk factors. Small vessel disease, we know, is more related to poorly controlled diabetes, hypertension, hypercholesterolemia. So, it's important to get screened for those conditions early on so that you can get started on medications to prevent vascular dementia in the first place. I would say Aricept is being used for some vascular dementia patients. I don't know how helpful it is, but it's really the only medication out there.
Yeah, and that's the point. You know, we're using these medications because that's all we have, and theoretically it should work. But if you look at the you know, the hit rate of it actually working, you know, we don't understand the underlying etiology for the most part.
The request was to comment on neuroplasticity.
I'll defer that to our functional neurosurgeon here.
I guess neuroplasticity can involve a lot of different things. One might be stem cells, which I think everyone always wants to talk about, but I think we all understand are still very far away from prime time. We do know that for things like stroke, for tumor, for dementia, that we're all trying to figure out how to put new cells back into the brain. But that is a real long road to hoe. Right now, we're trying to understand how through deep brain stimulation we might be able to affect things like memory or cognition. But again, that's also still all investigational. But those parts of DBS and cognition, I think those are things that we're going to earnestly try here.
Absolutely. And you know, whenever I think of neuroplasticity, I think of the pediatric population. You know, it is absolutely remarkable the recovery of brain injury in a pediatric patient and an adult. It's just, it's amazing. And that really, I think, is the key of what's happening at that level from a neuroplasticity standpoint, from a recovery standpoint, from an ability to repair the glia. In a pediatric brain cell versus an adult. So I mean, I think those are things that need to be untapped as well.
And to your point, Errol, you know, we have we're starting something where we're banking tissue from adults and also from kids, hopefully soon, so we can ask those questions about what are the support cells doing and how are they dealing with injury. So
that's a really important, I forgot about that, you're heading up that study for the tissue banking with CHOP.
That's right.
To be able to look at that. It's going to be really important. And actually, to some of the other discussions we were having, that, you know, the first time, and really credit to Jay Storm at CHOP, who said, let's stop keeping our data from each other and let's share our data. Let's take this tissue and not make it proprietary so that we can keep it in our own, you know, silo and share it so that we can work together for cure. So yeah, that's a really important point.
A couple cerebrovascular related questions. First, after blood loss to the brain due to stroke, has there been any research with getting those cells back?
I mean, I think that goes very much toward neuroplasticity and recovery from stroke. We're still not there with stem cells, as Dr. Sarkar mentioned. We are working with neuroprotectants after we're able to get the vessel open, injecting you know, calcium channel blockers, for example, to see if those neuroprotectants can save those cells that are sort of on the verge of whether they're going to live or die. But a lot of it right now is at the level of physical and occupational therapy. So, you know, mirror therapy for those patients who have neglect, and, you know, gyro gloves and things like that for people with movement disorders. And I think what we're seeing in terms of that, it tends to be more in the therapy arena.
And then the mechanism behind angioplasty when opening an artery in spasm and preventing respasm.
So that's specific to vasospasm from subarachnoid hemorrhage. So we know that there's this window after an aneurysm ruptures where the vessels are susceptible to what we call vasospasm or narrowing. And the risk of that is if the vessel's narrow enough that you can have a stroke because there's lack of blood flow to the brain. So we can do one of two things. Well, actually there are several things we can do. We start by raising up the blood pressure, infusing fluids, you know, just to try to get the blood volume up and improve brain perfusion. But then from an interventional standpoint, there's two major modes of treatment. One is calcium channel blockers, but those are very transient. So you inject them and you expect that the vasospasm is going to come back. Well, angioplasty is a lot more durable. So we use very tiny balloons and we plasty the vessel open. And this tends to be long-term Not always permanent, but usually it's just a one treatment and you're done, rather than bringing the patient back every day for calcium channel blockers.
Yeah, and it's really, there's multiple studies on outcomes of patients at centers that actually do and offer around-the-clock angioplasty. And there's technical nuance to it. You're blowing that balloon up in a very small a blood vessel in the brain, and the mechanism, as Mandy was saying, is that blood, those breakdown of blood products there's muscle in the arteries and they go into spasm, and the balloon is mechanical. It literally stretches those muscle cells to open up, and it's really remarkable where you can kind of get something that's this tiny little string, and then once you can get past it and blow that balloon up. But as we talked about at the session, those vessels can rupture, so it's not without risk, but it's durable.
Switching gears to spine, for multi-level lumbar, spondylolysis, pars defect, unmanageable by conservative treatments, is direct repair via screw hook technique still the most common treatment? And are there any other surgical interventions outside of fusion?
Yeah, I think Dr. Hochma and Dr. Stranger and I were talking about that. And if you have spondylolisthesis, if you have a pars defect, and conservative therapy is not working, then it's a fusion. There is no lumbar disc replacement, as we talked about. The bottom line is, if you hurt, you have to get fused. And even though a fusion might sound morbid, it's better than hurting.
Yeah.
How do financial limitations affect patients in need of services, and are there neuroscience-related foundations?
Yeah, that's a great question. And we had a long discussion last night about this. As I mentioned early on, G&I is really proud. We always have, we always will. We accept Medicaid everywhere we go, which a lot of surgeons don't do. The places we serve, Camden, Trenton, Chester, there's this, I think, misconception out there that if you don't have health insurance, if you have a certain type of health insurance, that you're going to get treated differently. And I think one of the, Mandy can speak to this as well as I can. One of the things that we were so proud of and actually was remarkable, in Trenton, which is the state capital, it wasn't uncommon where we treated high-ranking political figures, people that were well known in the public, and they got the exact same treatment as a homeless person coming in, exact same. There really weren't limitations at all. Now, where the limitations occur are when it's an elective procedure. But even then, and thanks to our hospital partners, we make that case. We never have an issue where there's somebody, we don't get a phone call saying, hey, this person has this insurance and you can't do that surgery because we're going to lose money, because they understand that we're making them money. The foundation aspect is incredibly important. And G&I does have a foundation, and you can go onto our website for that. And that's what we're really starting to build on, because what the foundation is critically important for our international patients. We've treated patients from the Dominican Republic, all over the world. And I'll make it sound like we're doing 100 a year, but over the years, we've done some really amazing care for patients in third world countries that need care. So the foundation is critically important for that. But our cause of what we're doing, all of us collectively, our mission is incredibly important, but we need that help from a foundation standpoint so that we can start doing things that are outside the box. We can have people like Natalie Goffman as a neuropharmacist, things that insurance companies don't reimburse for. So that's a great question.
Question about Philadelphia Neurologic Institute. What is the tentative date and where is the exact location?
So the tentative date is we are starting pre-construction next month, which means that we're going to start leveling the land and start doing all of that. And the location right now is right off of I-95. It's about 10 minutes outside of Philadelphia. It's on 36 acres, and it is in an incredible area, but it's right off of I-95. It's at right off of, I believe, the current exit 6, and we have planning to do a direct exit into the Institute.
If anyone else has any questions, please send them to the session Q&A. And while we're awaiting questions, anyone else have anything they want to share?
There was a leftover question from the prior session asking causes of craniosynostosis.
Oh, okay. So, you know, most craniosynostosis cases that involve a single suture are sporadic, and we don't really know why, but there are some syndromes that have craniosynostosis associated with them, including Apert's and Curzon's. There are also some genes. There are some evidence that if you've had a baby with craniosynostosis, the chances of having another baby with craniosynostosis is slightly, just very slightly, like 5–10% higher than in a normal population. And in terms of environmental factors, alcohol and smoking and certain medications have been associated. Again, there's no direct causative factor that we would know that, okay, if you do this, you're going to get craniosynostosis, but those are some factors that have been found to be associated.
Question about patient post-stroke. Have you encountered any patient who has encountered extreme pain post-stroke, who may have had little or no pain prior to the stroke, and treatment options is referenced?
Yeah, so the most common stroke that causes a pain syndrome is a thalamic infarct. And yes, the mainstay of treatment tends to be Neurontin or gabapentin is the other name. Maybe you have some other suggestions for that.
You're absolutely right about that, Mandy. So the posterior part of the thalamus, called the VC thalamus, gets infarcted, and that's where pain sensations are processed. I remember a guy that I took care of that would come see me in the wintertime with shorts and a t-shirt because he couldn't wear anything on half of his body. And we actually, it wasn't as, say, elegant as putting a DBS, but we used a spinal cord stimulator both in the neck and also in the thoracic spine to take care of his upper extremities and lower extremities. So there are indeed therapies, and we've done them.
Yeah, and the other syndromes with pain for stroke are muscle and joint pain from, the big one is shoulder. When people start, the rotator cuff starts to atrophy and it becomes extremely painful. And then in a delayed fashion, when they are able, it's like, not working out for a long time, then going to work out, that deep muscle pain. So it is an issue. And it actually reminds me, there was a question that you weren't here that was asked when we were doing our headache session about functional or any type of stimulation for headache, chronic.
So there's something, as both of you know really well, occipital neuralgia. So you can treat that with sort of spinal cord stimulator devices. But with regard to headaches, I think you hit it on the head that day, or both of you did. It's really a vascular problem, and it's not really an electrical problem. Right. So I think medications and embolizations, things like that.
Great. Well, I think we those are our questions, and I'm glad we got to all of them.
Absolutely.
So I want to, again, thank everybody so much. Our sponsors, this would not have happened without them. All of our speakers and our faculty, Ascension Studios for doing an incredible job with the audio-visual and just making all this happen from a technical standpoint. Kim Gelb, Rachel Donington. None of this would have happened without a lot of these people doing a lot of the behind-the-scenes work. And our moderator for 3/4 of the session here, Tom Kurtz, and Graham Thompson, who's made it all electronically possible. But really the biggest thank is to all of you out there. And we're going to continue to do this. We're going to get your feedback. We're going to continue to build on this. And stay tuned, because we're going to continue to do these types of mini lecture series throughout the year. We're going to be and record them, so there'll be different subjects, so you can tune into functional, pediatric, vascular, cognitive, everything. And we're even working right now. Graham Thompson came up with a brilliant idea just yesterday of having something for patients, so that we can do something just for patients and not clinical, but to the earlier question, how do you navigate through a health system? How do you get to a doctor if your insurance won't let you? You're a hospital patient for an emergency and you're getting all these bills. You know, really from that standpoint, how to navigate through things that nobody really teaches you or tells you, and there's really no resources for. And last night, we had an incredible patient series with all the physicians of GNI were on. And we had, 100 patients on there, all able to ask questions and chat with each other. It was really an incredible experience. And I think the patients were just blown away that not only were they had access to healthcare providers, but literally, I mean, there was a rare syndrome that a patient had that I'd never heard of, literally never heard of. I think it was probably a question on medical school, in my clinical exams or something. And Dr. Farmer was like, I see those patients, it's really rare, but this is what you do. And it was incredible. So we want to do more of that too, to reach out to the community. But again, thank everybody. It's going to be a beautiful weekend if you're in this part of the neck of the woods. So enjoy your weekend, have a great time, and thank you, and we'll see you again real soon.